In this lecture, we'll review methodological context for approaching Anne Fadiman's The Spirit Catches You and You Fall Down. As Fadiman says in The Spirit Catches You and You Fall Down, the culture of biomedicine in the West has its own interests, emotions, and biases. Western medicine is biomedically focused. It's Cartesian, as Fadiman says. And what does that mean? The culture of biomedicine is dualistic, and it rationalizes what it sees. There is an assumed right and an assumed wrong way to medically approach illnesses, and the unrationalized or unrationalizable, the social and psychological factors that can shape our experiences and trajectories of illnesses and disease, are often overlooked. We've talked before in this class about how certain groups of people, certain bodies, like those of African Americans, Latin Americans, Asian Americans, Native Americans, and Alaskan Natives, face disproportionately higher rates of chronic conditions like asthma, cancer, heart disease, diabetes, high blood pressure, obesity, anxiety, and depression. And we've talked about how these disparities should not be chalked up to simple biological differences. In 2008, the World Health Organization identified a variety of social conditions that act as proxy determinants of disease and death, including poverty, food insecurity, social discrimination, poor housing, and low occupational status. And all these things result in health inequalities. We should be suspicious of health differences in different groups of people and look to our environment as well. This week we're focusing on cross-cultural medicine. We've looked at body identity, we've looked at identity formation or internal senses of selves alongside illness experiences, and Murphy was a solid foray into American culture alongside these ideas. For this week we'll consider the impacts of cultural differences on patients and healthcare providers. We all generally know what culture is. Culture is the collection of beliefs, norms, and practices of a particular group of people, whether that group be ethnic, social, racial, religious, or otherwise. What we often don't think about is how grouping people into different cultures exercises a certain kind of power dynamic. Think, for instance, of the way we say someone is cultured versus someone who's not. To have culture is superior to those who are perceived as uncultured. But who are the peoples who are considered uncultured? In America, we recognize that the groups who have been traditionally considered uncultured are those who have historically been biased against. The minorities, in general, African Americans, Hispanics and Latinos, Native Americans, etc. Meanwhile, what is considered cultured has traditionally been cultivated by a largely white, middle-class, patriarchal society. In our last lecture, when we talked about natural hair in the African American community versus European American community, we saw how there's a detrimental tendency to arbitrarily default the designation of class, sophistication, and culture to the hegemonic side, the white side. And the fact that we typically call minority cultures subcultures not so obliquely belies the power dynamic between the defaulted white America and the supposed lesser cultures of minority groups. The privileging of hegemonic groups is so naturalized into all facets of cultural knowledge that sometimes it's hard to pick out. In literature, for instance, the aesthetic of realism typically critiques society from a white middle-class perspective, but we don't talk about realism in this way. We just call it social realism as though it's realism of society as a whole. There are also different types of realism that are not given as much weight as social realism, and these typically focus on non-white, non-hegemonic culture. Regionalism and local color, for instance, seek to preserve folk stories, dialects, culinary knowledge, behaviors, and so forth in the face of what then was encroaching industrialism and a general assimilation into white culture. These types of realism have been accused of not being realistic enough because they do things like employ folk figures like the trickster of slave narratives and Native American stories, and emphasize the general feeling of an area, for instance calling a town in South Georgia sleepy rather than objectively detailing every crooked nail that it took to erect Jim Bob's house. That we prioritize and validate one type of realism over another may seem trivial. We might even agree that an aesthetic called realism should focus on objective matters such as social issues at large, rather than regional impressions and folk tales. But again, the issues that have been identified as social are those that are not representative of marginalized groups of people, and thus when we allow ourselves to think like this, we're accepting that certain values and peoples are more important than others, and we're participating in the naturalization of arbitrary values. In other words, what makes social realism more important than local color? Are the issues of white, middle-class people more real, while the issues of African Americans, Native Americans, Latinas and Latinos, etc. are not real? Parsed this way, the dangers of hegemonic cultures seem obvious. but maybe we're still hesitant to give equal consideration to traditional and alternative medicines alongside Western biomedicine. So keep in mind that the privileging of white culture is evident in Western medicine as well. Consider, for instance, that yoga is a type of alternative or supplementary practice, but as something that has become a hallmark of white middle class culture, it does not face the same suspicion and scrutiny as other non biomedical approaches from non Western cultures. Again, this dualistic thinking is what propels our culture of biomedicine. There is real medicine, and then there are not real medicines. There are cultured peoples and uncultured peoples. And because this is a power dynamic, we must be prepared to see how behaviors and structures that intentionally or unintentionally reinforce the threat of difference may invite indifference, incomprehension, and or even hostility from both sides, patient and healthcare providers alike. Cultural differences can elicit feelings of inequality for patients. Simply being in a hospital can feel oppressive. Healthcare institutions often represent a loss of personal choice. We saw this in Plath and Kane. Today, patient care is so specialized that we often don't get to know our providers but are juggled between several different specialists. The medical gaze itself is objectifying. Admitting, so to speak, that one has an illness, disease, or disability carries with it social implications and potential negative connotations as well. So there are already lots of reasons why people are uncomfortable in a healthcare setting. Then add to this the quagmire of cultural differences, and we've got ourselves a potentially messy situation. Native Americans who traditionally prize carefully deliberated conversations might complain that doctors speak too quickly. Some cultural groups, including Mexican, Filipino, Chinese, Russian, and Iranian, may expect the doctor to discuss the prognosis with the family first so that they may decide how or whether they'll deliver this information to the patient, and communicating directly to the patient may be perceived as crass, uncaring, and distressing. Some groups believe that only God may know when an individual may die. We saw this with the Hmong people in Fetterman's work. And so, if a physician says that a patient only has a certain amount of time left to live, it's seen as suspicious and threatening, since the only way anyone can know that is if they're planning the individual's death. Lack of eye contact across various cultures means different things, from respect to disinterest and shame. In Navajo tradition, eye contact threatens the loss of one's soul. Some groups of people, like Orthodox Jews and some Islamic sects, don't allow opposite sex contact, such as shaking hands, and so forth. These are some pretty common examples of cultural differences you might encounter in a clinical setting. Faced with such uncertainty and unknowns, patients may withhold their personal views about what they feel is wrong or what actions, especially non-biomedical, they've already taken. They may be reluctant to disclose their beliefs, herbal therapies, home remedies and practices, and religious efforts at healing. They may fear their doctor's disdain for these activities, and ultimately, they may withhold or slant certain information in order to avoid being labeled, as well as to cope with their anxieties about illness. So what should healthcare providers do in response? When it comes to cross-cultural medicine, two things must be in place: cultural competency and trust. Cultural competency is the ability to self-assess one's own biases in order to not only understand, but respond to the cultural needs of others. In some ways, this entails a conscious application of empathy. You must not only be able to recognize someone else's needs, but be able to respond. I say this pointedly because empathy is specifically defined as comprised of these two things: recognition and response. Someone with autism can respond, but may not be able to recognize. They can be taught to recognize and thus empathize. In contrast, a psychopath can recognize but won't respond, and moreover cannot be taught that desire to respond. That's an example of someone with an extreme lack of empathy. Cultural competency asks that we exercise this recognition and response to address cultural differences, or differences, for instance, in language, literacy, gender roles, sexual orientation, physical and mental ability, socioeconomic status, occupation, religious beliefs, traditional mores, social behaviors, and so forth. There are some systemic things each hospital or healthcare setting can employ in order to improve patient-provider interactions. You've probably heard of these things before. Measures include providing interpreter services, retaining minority staff, coordinating with traditional healers, establishing clinical care in geographic areas accessible to underserviced populations. Fadiman talks about some of these institutionalized courses and methods, such as incorporating Arthur Kleinman's 8 ethnographic questions for the patient. What do you think has caused your problem? Why do you think it started when it did? What do you think your problem does inside your body? What are the most important results you hope to receive from this treatment? What are the chief problems your illness has caused you, etc.? But miscommunication affects everyone badly. And so communication is what we're going to focus on. Cultural differences can lead to misunderstandings, not just on the patient's part, but on the provider's part as well. The textbook example of patient-physician miscommunication and cultural difference can be seen in the Asian practice of coining, where a coin, possibly heated or oiled, is rubbed on patients' backs to draw out their illnesses. It's an alternative practice intended to heal the patient, but it also results in red welts on the back, and these have been mistaken by physicians for abuse and summarily reported in some cases, especially those involving children. We can already see how this is similar to the case Fadiman is recounting. A less severe example, but still pretty common one, pertains differences in time perception. Some cultures, like Latino cultures, encourage a relaxed sense of time, but a healthcare provider may perceive tardiness as a sign of unkemptness, disrespect, or laziness. So let me repeat this point. We've touched on similar ideas before when we talked about racial and gender apathy, but I'm reiterating all this in order to underscore a major point, that we frequently operate under certain hegemonic or meta-narrative assumptions without being consciously aware of how these assumptions play significant roles in dictating our beliefs about what is professional, what is polite, and even, yes, what is healthy and unhealthy. So if we subscribe to the culture of biomedicine, we must likewise be aware of our own biases and assumptions. This self-assessment is the first step towards cultural competency. So the self-awareness that comes along with cultural competency requires that we become aware not just of the stereotypes we might be subject to in the eyes of others, but also how we may have our own biases and preconceptions, and how we may have limitations on what we know about medical issues across cultures. Because of our limitations, cultural competency in part simply takes time and research to establish. If you know you have limited knowledge about a culture, take the time to find out more about a people's traditional beliefs and medical knowledge. At the same time, and something you can practice every day in almost any professional or personal setting, you should be exercising means of establishing trust. This is where our class's focus on narrative is significant. Building trust is essential and often involves breaking down the patterns of neutrality, distance, and non-involvement that physicians and healthcare providers are encouraged and trained to use. I'll say this again, trust, like empathy, requires some level of a breaking down of barriers. It should go without saying that if it feels like there is an unequal power dynamic, such as the privileging of one culture over another, it will be all the more challenging to establish a sense of trust. Remember that the point here is not to be right, and this goes for many aspects of our personal and professional lives, not just medicine. The goal is, instead, to establish a relationship of trust and line of communication so that patients will confide their concerns and experiences and reciprocally listen to doctors' orders and recommendations. So how can one establish trust? It might be helpful here to conceptualize relationships in general in a spatial sense. Formal relationships entail distance between people, while informal relationships entail intimacy. Think, for instance, of the way you might call your professors or employers by a certain title like doctor or mister or sergeant, whereas you might call your close friends by their first names or nicknames. The language we use here implies distance and formality, or intimacy and informality. Why is this important? Well, which one do you think would be more appropriate for establishing trust? Our first guess might be to say formal relationships are necessary for establishing trust. This can appear true in at least one sense. A composed, equanimitous doctor who never reveals his or her uncertainties and doubts can indeed establish confidence in patients. But arguably, this is less about trust, as in you trust this person will not judge you, or you trust this person sees you as an equal, and more about security. Formal relationships, because of that distance, imply a kind of undemanding comfort or safety. This is why formality is the go-to for first meetings and impressions. You don't want to demand too much of people when you first meet them in order to avoid impinging on their personal bubble or comfort zone. However, the more distance you put between yourself and anyone else, the less likely it is that you'll feel you can truly trust that individual. Informal relationships, which entail closeness, that breaking down of barriers, thus imply trust through vulnerability. We're eliminating, in a sense, that safety factor in exchange for a functional reciprocity. For instance, the first time you meet someone, let's say they let slip something pretty personal or embarrassing. If you react in a way that shows you're judging them, you're creating distance between yourselves and demonstrating that you don't want an informal or intimate relationship, but something that conforms to formal mores of behavior. If instead you react by admitting some personal or embarrassing story yourself, you have reciprocated vulnerability and established equality, that person might be more likely to trust revealing things to you in the future. So, how does this translate for medical humanities and a class on pathographies? We have to be both formal and informal. We want patients to trust healthcare providers in a way that makes them feel secure, as well as in a way that makes them feel respected. One of the best ways we've found to establish that appropriate level of trust between physicians and patients is through narrative. Typically, when a patient visits a doctor, the doctor asks a series of questions, but these questions can be problematic for a number of reasons. On one hand, the formality of an interrogator and interrogatee implies objectification and an unequal power dynamic, gazer and gazee. For some cultural groups, they may even perceive the doctor as being a bad one, since asking questions would imply that he or she doesn't know what's wrong when it's supposed to be his or her job to know. Questions can also be oddly informal and intimate in the worst sense. They can be painfully direct and invasive. Narrative, on the other hand, allows for the kindly indirectness of a formal approach while inviting the informality of equal participation from both parties. Narratives can be directed with statements such as, "Tell me about what your grandma would say about this illness," or "Tell me what you think I ought to know." If certain subjects are offensive, narrative allows for the formal use of analogy, implication, and circuitry to facilitate communication of the needed information without anyone suffering embarrassment. At the same time, it allows patients greater control in shaping the terms of communication while speaking with their healthcare provider and thus helping to establish a relatively reciprocal connection. In the end, the assumption is that we trust someone who's listening to our story because our voices feel validated and the relationship doesn't feel simply utilitarian. It also allows for colloquial language to avoid heavy use of medical jargon that otherwise might be unhelpful and discouraging for patients of certain classes, educational backgrounds, cultures, and languages. And as an added plus, it facilitates the communication of information that healthcare providers might not have initially known to look for, helping to expand medical foci and knowledge. And this last point is why it's so important that we cultivate the analytical skills to break down narratives, so that we may be prepared for that delivery of unknown knowledge when it comes.